So when you're talking about gas exchange, as we mentioned a couple slides ago, the thickness of the membrane of the alveoli is important. So your alveolar membranes are only 0.5 or half of a micrometer thick, very, very small. Because it's so small, there's little obstacles, there's little bit that causes, that can stand in the way of diffusion of the oxygen into and out of the blood. If a person has pulmonary edema, meaning again that they have some level of fluid in the tissues of the lungs, then this can be caused by left ventricular failure. So remember that the left side of the heart is responsible for taking oxygenated blood and pumping it through the rest of the body. If that left side of the heart fails, if it can no longer pump the blood to the rest of the body, or it can't do it effectively or efficiently, then that means that some of the blood that goes into the left side of the heart will remain in the heart and not go into the rest of circulation. Well, the blood, remember, just came from the lungs. And so if there is a backup, then that fluid is going to back up into the place where it just came from, and that is in those lung tissues. So that can cause this pulmonary edema that will decrease the amount of oxygen that can travel from the air into the blood. In pneumonia, as I mentioned in the earlier image, you have a thickening of that membrane because of edema. You have also an increase in mucus and other fluids that are in the alveolar spaces. And so when that membrane is thicker, when you have that mucus that lines that membrane, those gases have a farther way to go to get from the air into the blood. And sometimes if it gets too thick, it can't equilibrate. It can't equilibrate fast enough to keep up with that flow. So the person's body gets less and less oxygenated. This is why you have people walking around with oxygen tanks so that they can get a constant influx of increased amounts of air to hopefully balance out the fact that their body cannot resolve or get as much oxygen in by itself. Ventilation perfusion coupling, this basically just talks about the ability to match the flow of air to the flow of blood so that you can get a good amount of oxygen into blood flow. So I want you to read this part on your own. Look at this diagram as well as this diagram to help you understand that concept. And if you have a question, let me know. So gas transport. Gas transport is the way that gases are carried from the alveoli to the rest of the tissues and vice versa, from the tissues to the alveoli. Oxygen is transported mostly bound to hemoglobin. So remember that hemoglobin is that component of red blood cells that has iron in the middle of it. And this component is where is what attaches to your oxygen ions. So oxygen ions that come into the bloodstream from the alveolar air sac will meet up with a red blood cell and attach to the hemoglobin in the red blood cell. And that's how it gets to from one place to another. Only 1.5% of oxygen is actually dissolved in the plasma itself, non-bound to hemoglobin. Most of it bound to hemoglobin. So remember this 98.5% because this is how much is bound to hemoglobin, and that number is important, which then means you'll need to know the 1.5%. But if you know one, you should know the other. Carbon dioxide is transported in several different forms. So 90% is hydrated, meaning that it is changed, the form of it is changed to carbonic acid. This dissociates into bicarbonate ions, so that is 90%. 5% of it is bound to proteins, and 5% is dissolved in the gas, as a gas in plasma. So whereas 1.5% of oxygen is dissolved in the plasma, you have 5% of carbon dioxide dissolved in plasma. The rest of it in transport, 90% is carbonic acid, 5% is bound to proteins. In exchange, so that was transport of carbon dioxide. In exchange of carbon dioxide, 70% of it is the form of carbonic acid, 23% comes from proteins, and 7% comes from plasma. So oxygen in arterial blood carries about 20 mils of oxygen per deciliter. Your hemoglobin is a molecule, again, that is specialized for oxygen transport. So the way hemoglobin is put together, you have 4 protein molecules. These are the globin molecules. Each of them have a heme group. Each of those heme groups can bind an oxygen molecule to an iron atom. One hemoglobin molecule can carry up to 4 oxygen molecules because you have these 4 globin proteins that can each bind an oxygen. 100% saturation of hemoglobin. You have 100% saturation of hemoglobin when you have all 4 molecules, globin molecules attached to an oxygen molecule. It's 50% saturated if you only have 2. Oxyhemoglobin is what it's called when the oxygen is bound to hemoglobin. So oxyhemoglobin is the name of the hemoglobin that has an oxygen bound to it. Deoxyhemoglobin is that hemoglobin when you have no oxygen bound to it. These terms are important to know. Carbon dioxide is transported in 3 forms. We just mentioned that. You have the carbonic acid, you have the carbamino compounds. So the carbamino compounds, remember amino acids are the breakdown products of proteins. They are the building blocks of proteins. So carbamino compounds are, where is it? Your carbamino compounds is this. It is this 5% of your carbon dioxide that are bound to proteins, or this 23% that comes from proteins. Those are your carbamino compounds. And then you have some dissolved in the plasma. We already talked about this. So read this again to help you understand this. Now, to help you understand this. All right, so read over that. As well as this. This is again a repeat of what was just stated, so read that. Carbon monoxide. So carbon monoxide, make sure that you know that carbon monoxide is very different from carbon dioxide. The name will tell you the structure. So carbon monoxide, that is 1 carbon molecule with 1 oxygen molecule, that's CO. Whereas carbon dioxide is CO2, where you have 2 oxygen molecules combined to a carbon molecule. Carbon monoxide is a poison, is considered a poison because carbon monoxide actually has a greater affinity for the binding sites, the oxygen binding sites on the hemoglobin molecule, meaning that if a carbon monoxide molecule and an oxygen molecule are both present, the carbon monoxide molecule is going to be more likely to bind to this hemoglobin molecule so that the oxygen cannot bind. And when a person has a lot of carbon monoxide gas in their presence, they're going to inhale, and more of those hemoglobin molecules are going to bind to carbon monoxide instead of oxygen. When that happens, the person doesn't have enough oxygen to nourish, to feed the cells of the body, and that's where the problems exist. Carbon monoxide is colorless, it is odorless. It's colorless and it's odorless, meaning that people don't know when there is carbon monoxide near them. This is why having a carbon monoxide monitor is important, or a carbon monoxide detector is important in a home. When we had the storm and power was out and a lot of people have to use generators, you have so many deaths due to carbon monoxide poisoning. The carbon monoxide gas that is generated by the generator, people inhale it not knowing. They sleep in a room where there's a lot of carbon monoxide, and because there's a greater affinity, they end up passing away because they lack oxygen. So carboxyhemoglobin is when carbon monoxide binds to the iron molecule of hemoglobin. It binds 210 times more tightly than oxygen. So when I said that it has a greater affinity, it has like a really higher, much higher affinity for that hemoglobin than oxygen does. So it ties up that hemoglobin for a long time. Basically, once it's bound, it's very hard for it to come off of there. For non-smokers, you have less than 1.5 of the hemoglobin occupied by carbon monoxide. For those people that are smokers, you can have up to 10% occupied by carbon monoxide in those who are heavy smokers. So it can be really lethal very quickly. Again, because your body needs oxygen, your cells need oxygen, and if carbon monoxide binds to those sites, then it's very hard to get it off. And the more hemoglobin molecules are bound with carbon monoxide, the less oxygen is available. So, part of what is monitored by your body is how much oxygen the brain is getting, or the pH of the brain. So your central chemoreceptors in the medulla, in that portion of the brainstem, will produce about 75% of the change in respiration induced by this pH shift. You have carbon dioxide that crosses the blood-brain barrier, and then it reacts with the water in the cerebrospinal fluid to produce this carbonic acid. The hydrogen ions from the the carbonic acid will stimulate those chemoreceptors. Since you don't have a whole lot of protein in your CSF. When you have this increase of hydrogen ions, that will stimulate your peripheral chemoreceptors as well, and this will produce 25% of the respiratory response of pH changes. So this is how your chemoreceptors will monitor your blood pH and what it will do if that pH of the brain shifts. Acidosis is a condition when your blood pH is lower than 7.35. Alkalosis is when your blood pH is higher than 7.45. These numbers are very close together because pH is very closely monitored and maintained by the body. And so even that slight shift in pH can cause major problems. So acidosis, you must know these numbers. Acidosis lower than 7.35, alkalosis higher than 7.45. Hypocapnia. Hypocapnia is Partial pressure of carbon dioxide that is less than 37 millimeters mercury, where the norm is 37 to 43. This is the most common cause of alkalosis. Hypercapnia is when you have the partial pressure greater than 43. Remember that normal is between 37 and 43. And this is what causes acidosis. This slide, very important to know. Respiratory acidosis and respiratory alkalosis is when your pH imbalances are resulting from a mismatch between the rate of pulmonary ventilation and the rate of carbon dioxide production. So your breathing rate is either higher or lower than your body is producing carbon dioxide, and that will change the pH of the to either be acidosis or alkalosis. A person who hyperventilates can cause a restorative hemostatic effect in response to acidosis. So if a person is acidotic, then they can blow off, quote unquote, blow off some of the carbon dioxide by breathing faster. That will get rid of some of that excess carbon dioxide to change the body's pH. Hypoventilation can be the corrective measure that your body takes if you have alkalosis. So this will allow some of the carbon dioxide to accumulate in the body faster than you exhale it. Because you are not blowing off as much carbon dioxide as quickly, it stays in the bloodstream and can help to restore some of that body's pH, can decrease that body's pH. Ketoacidosis is a condition that is a little bit more severe because not only do you have acidosis, but it's caused by something other than breathing. So this is acidosis that's brought about by rapid fat oxidation, releasing acidic ketones. This is what happens in diabetes, uncontrolled diabetes. So the fat is oxidized. It is releasing those ketone bodies that are acidic. This causes an acidic state of your blood, and it can cause problems. So this induces that Kussmaul breathing or that Kussmaul respiration. This is hyperventilation that is trying to reduce carbon dioxide concentration to compensate for the acidity of the ketone bodies. Ketoacidosis in diabetes can be a very serious condition and require hospitalization to have the person to get back to normal. Hypoxia is deficiency of oxygen in their tissues or the inability to use oxygen. So again, we're talking about the difference between taking something in and actually absorbing it. So your body can actually have oxygen and not be able to use it, or it can just not have much oxygen. Hypoxia is a consequence of several different respiratory diseases. Hypoxemic hypoxia is the state of low arterial pressure of oxygen, partial pressure of oxygen. This is usually because of inadequate pulmonary gas exchange. So if a person is at high elevations, there can be an oxygen deficit because their body hasn't compensated for that decrease in oxygen pressure. If a person has impaired ventilation, for example, they're drowning, they're not able to breathe air because they're underwater. If someone breathes in a foreign objects, like little kids that will stick things in their nose and it goes into their lungs, that decreases ventilation. A person has respiratory arrest. If they stop breathing, obviously that's impaired ventilation. or they have degenerative lung diseases where the lungs are not able to ventilate properly. Then you have ischemic hypoxia, where you have inadequate circulation of blood, and this can be caused by congestive heart failure. Anemic hypoxia is due to anemia that results from an inability of the blood to carry adequate oxygen. And if you remember, there are several different types of anemia that can cause this. So it's not just iron deficiency anemia. There are several different types. Please go back and refer to those so that you can be more familiar with the different types of anemia. You have histotoxic hypoxia. This is when you have metabolic poisons such as cyanide that prevent the tissues from using oxygen. So histo meaning tissues. So this is hypoxia because of toxemia of the tissues. And then you have cyanosis, which is basically an outward sign of hypoxia. This is when your skin turns blue because you are lacking oxygen. So the skin of the lips, the fingertips, etc. Those are the two most common areas that will start turning blue when your body has decreased oxygen available. There is a such thing as oxygen toxicity. So if a person breathes too much oxygen for a length of time, it can cause more free radical damage. It can destroy enzymes. It will damage nervous tissue. It can lead to seizures, coma, and death. This is why those oxygen tanks that people carry have to be calibrated. It can never be 100% pure oxygen. Even with those hyperbaric oxygen chambers that have a higher amount of oxygen, people will go into it, but they're limited in how long they can sit in it, because after a certain amount of time, it becomes less therapeutic and more toxic to the person and could lead to more serious diseases or more serious conditions or even death. So the way they discovered this is that in the early days of using the hyperbaric oxygen chamber, they basically tried to help people who they thought needed more oxygen. And what they found was that with premature infants in particular, those that were put in hyperbaric oxygen chambers, they had retinal damage, which means that the retina, the portion of the eye that helps you see, was damaged. And so because they had so many infants that had this outcome, they discontinued the use of hyperbaric oxygen chambers for that population. COPD, chronic obstructive pulmonary diseases. These are long-term obstructions of airflow and substantial reduction of pulmonary ventilation, basically meaning that you have more trouble with air being able to come in and out of the bronchioles, as well as a decrease in how much oxygen and carbon dioxide can go across the alveolar membranes. Your major COPDs are your chronic bronchitis as well as emphysema. It's almost always associated with smoking, but not 100% always, but most of the cases of your chronic bronchitis and emphysema are because of smoking. Some other risk factors are air pollution, occupational exposure to airborne irritants, and hereditary defects. For example, I actually have an elder cousin who was a bus driver in Chicago for several decades. And he now has COPD not because he smoked, because he never did, but because he was driving a bus, and that bus gave off these air pollutants, and whatever other air pollution was in the Chicago air for all the decades that he was driving caused him to have COPD. right? So most of the time COPD is associated with smoking, but sometimes it's not. It is other irritants that can cause damage to the lungs, like those that are mentioned. Chronic bronchitis, you have severe and persistent inflammation of that lower respiratory tract. Do make sure that you know the difference between the lower and the upper respiratory tract, and remember what inflammation is. So the goblet cells will enlarge and produce excess mucus. You will have immobilized cilia. So remember that the cilia are those hair-like cells, and part of the reason why those line your mucous membranes as well as your digestive system is to help move that mucus from one place to another, help get it out of the body when it catches a virus, a bacteria, dust, pollen, or whatever. It will help to, the mucus will capture those things, and the cilia will help to move it by brushing it, in a particular direction. Well, in chronic bronchitis, that cilia is immobilized, it's basically paralyzed, so it cannot remove the mucus, which means that this person will have an increase of mucus in those areas. It becomes thick, it becomes stagnant because it's not moving. And then you have now a ideal place for bacteria to grow because it's dark, it's moist, and it's full of whatever nutrients and oxygen and stuff the bacteria need. Smoking also compromises that the macrophage function inside the alveola. So when you smoke, those macrophages get paralyzed for some time so that they cannot function the way that they're supposed to. They cannot remove the smoke that has just been inhaled. So now you have this smoke accumulation. Symptoms of chronic bronchitis include hypoxemia and cyanosis. Emphysema, as was mentioned, is when you have the walls of the alveola break down so that you have fewer and larger spaces in the lungs, which decreases the amount of, decreases the amount of, I can't remember what I'm thinking about, but decreases the amount of membrane available for gas exchange. The lungs will become fibrotic, meaning that they will become hard and basically like a scar tissue, which means it's less elastic, so that the lungs cannot recoil once they expand. So if they expand, they remain expanded because they're fibrotic and less elastic. They can't bounce back into place. So the lungs become flabby and cavitated with large spaces. These air passages will then collapse, which will continue to obstruct the flow of air. The person will then have trapped air in the lungs, and that will keep increasing the space of the lungs because remember there's little elasticity, so those lung tissues cannot recoil back to where they were. So the lungs themselves become bigger and bigger, and these people eventually become barrel-chested. Their chest will literally start to take on the shape of a barrel because the lungs are getting bigger and bigger because they cannot recoil to their normal size. Then you will have weakened thoracic muscles. So these accessory muscles you'll have to spend much more energy in order to breathe because these muscles are weaker and weaker. So all of these are signs, symptoms of emphysema. COPD reduces vital capacity. So you remember your vital capacity is how much you're breathing at rest, that more shallow breathing that we tend to do, that decreases with COPD. It's already shallow, but with COPD, that is even reduced. So they have to, their breathing is much more labored and forced because that natural rhythm of breathing is decreased. COPD causes hypoxemia, hypercapnia, and respiratory acidosis. And cor pulmonale is a condition where you have hypertrophy and potential failure of the right side of the heart due to obstruction of pulmonary circulation. Adenocarcinoma. This is a type of lung cancer or a type of cancer. This one in particular originates in the mucous glands of the lamina propria. So look that up so that you can know where that is. You have small cell carcinoma, also called oat cell carcinoma of the lungs. This is a type of lung cancer. This is the least common lung cancer, but the most dangerous. It is named for the clusters of cells that look like oat grains when you look at them under the microscope. These will originate primarily in the bronchi and then invade to other parts of the lung and quickly metastasize to other organs. Small cell or oat cell carcinoma. Do know the differences between these two. 90% of lung cancers will originate in the mucous membranes of the large bronchi, those primary bronchi. The tumors will invade the bronchial walls, which will compress airways and may cause atelectasis. Look that up so that you can see what atelectasis is. Often the first sign of this is when a person coughs up blood. Metastasis usually occurs very rapidly. And by the time the person is diagnosed, they've already have some metastasis. The common sites of metastasis are your pericardium, the heart, bones, liver, lymph nodes, and brain. Prognosis for people who have been diagnosed with this is relatively poor. Only 77% of people will survive up to 5 years. So usually the other 93% of people will pass before 5 years after being diagnosed. So this is what this looks like. So you have a healthy lung here. This is the mediastinum. So the mediastinum is that central portion of the lungs that connects the bronchi to the lung tissue itself. And so you have this lung that is healthy, it's pink. This is normal. A smoker's lung looks like this. So when you smoke, you have a bunch of tar buildup and other toxins that are being inhaled into the lung space. And this causes this change in color and eventually the change in the structure of the lungs. And this are what tumors of the lungs look like, the carcinomas of the lungs. And that's it. That is the respiratory system, and we will talk about it in class.